we actually have a very broad program across subtypes of MS. So we're covering relapsing MS, non-relapsing secondary MS, and primary progressive MS. And I think we're all keenly awaiting the phase 3 result to really define where in the treatment paradigm, especially tolebrutininb will fit.
Yeah, and I would add to that, there's a lot of discussion at this Congress around so-called smoldering MS, and this part of MS that is driving a lot of disability, a lot of worsening, even in patients who are treated with high-efficacy therapies. And we believe that this has to do with this compartmentalized neuroinflammation, these things going on within the central nervous system that the currently available therapies aren't really touching. And we believe and hope that tolebrutininb can show some effect there, and looking forward to seeing the phase 3 results.
And I would maybe add to that, there were some more tangible sort of illustrations of that also at this meeting. There was specifically one case report that was quite dramatic. Unfortunately, a patient that passed away, and the patient was B-cell depleted, but had significant other cellular components like monocyte macrophages and CD8 T cells. So it was a dramatic illustration, but I think it goes in line with this remaining unmet need in MS to go beyond what the current therapies can offer.
We have many therapies available in MS today, and without a doubt, someone being diagnosed in 2023 is in a much better position than someone 20 years ago, 30 years ago. So, and that's great news for the community. At the same time, we recognize that even with the available therapies, we have a lot of patients who are still getting worse. And we believe that worsening is driven by this so-called smoldering MS happening within the CNS that the available therapies don't address very effectively. And we believe that BTKs, including tolebrutininb, could offer promise in that area.
And we think there's actually, we often hear this, well, there are many available treatments, and how is the new fit? When we think about it, we actually think that when we look at specific segments, it gets quite different. If you look at progressive disease, there's not a lot of available treatment. So there is really a high unmet need, and the very few options that are available are not particularly effective. And there is even in RMS a segment that is not so well covered. It's what we consider the high efficacy segment, where there are quite few options. So we think those are some specific segments, the progressive, the high efficacy, where we actually do need additional alternatives. And there is a relatively large amount of such patients. It's not uncommon to have progressive components in the MS, or we also think that there may be room to treat even more patients and even earlier patients with high efficacy therapies. And I think many physicians would appreciate having more options. So it's a little bit paradoxical, perhaps, when saying, well, there's so many treatments, but it depends on the segment you're looking at, and certain segments are not well covered.